Today, we will be asking the question, is MRD negativity the goal of myeloma treatment? To help answer this question, we will hear from Dr. Hultcrantz. Dr. Hultcrantz is a board-certified hematologist who specializes in the treatment of multiple myeloma and related plasma cell disorders, including the precursor disorders such as MGUS and smoldering myeloma at the Memorial Sloan Kettering Cancer Center. He is focused on further optimizing treatment strategies for people with multiple myeloma and offers a variety of modern treatments, including clinical trials and novel immunotherapies. She's also working on measures to continue to improve patients' quality of life while receiving treatment for multiple myeloma. Dr. Hultcrantz has a particular interest in studying mechanisms and markers of progression from precursor diseases to multiple myeloma. A particular interest to me, she's also working with her colleagues to develop targeted genomic tests for disease characterization and measurement of minimal residual disease. I'd like to now turn the time over to Dr. Hultcrantz. Feel free to unmute and start your video. And before we start, Dr. Hultcrantz, will you correct me if I didn't say your name correctly? Is it Dr. Hultcrantz?
Yes, no, that's perfect. It's actually Swedish. So in Swedish you say Malin Hultcrantz, but that's that's a little bit too much to expect here. So Dr. Hultcrantz is perfect. That was excellent. Thank you so much for that very kind introduction. And thank you so much everyone for being here. And today we're going to talk a lot about MRD because there's so much to cover, and I really look forward to all of your questions after. So I am going to start here with then sharing my screen. Give me a second. Here, there, and then here. So for MRD and multiple myeloma, there. So first question then is the heading of this talk there. Is MRD always the goal? Short answer is yes. And if it was that simple, then we could kind of end the talk here. But that's not what the goal is. We're going to discuss every single or a lot of the different aspects and why it is important, and sometimes when it's not important, and there are other things also that matter. So yes, it's complicated. First of all, what is MRD? Minimal residual disease, or measurable residual disease, as many now call it, is a small number of myeloma cells that may remain in the body after treatment or during remission. And a lot of people they like to compare this to kind of the iceberg here. So if you compare it here, this up here is the disease that we can see and measure. We can see it on the scans. We can see it on in the blood. And then as we treat, the disease gets lower and lower. We come into what we call a complete remission, stringent complete remission, meaning that we can't really see it when we even look in the bone marrow. And then when we do very sensitive methods, here is then when we get down to the MRD testing, the molecular or flow complete remissions. And if we get rid of all of these cells, that's when we're aiming for a cure. So the level, so actually, when we talk about MRD, I think it's actually almost better to kind of flip the iceberg upside down to see, because there's really not that much kind of left. So the most of the disease that we see on the PET scans or any of the MRIs or so, we're going to get rid of that and what we see in the bone marrow. So really what we're talking about is that minimal, very small portion of cells that we then try to detect and try to even get rid of in the bone marrow. And there are different levels, and this is getting increasingly important. So the MRD level, that depends on which technique we use, and then how good the sample is and how good the technique is to detect these different cells in the bone marrow. So the fewer cells, of course, the fewer myeloma cells we have, the better. That's always going to be the truth. So the minimum detection level when we talk about MRD is 10 to the minus 5, and that means that we can find 1 myeloma cells in 100,000 normal bone marrow cells. 10 to the minus 6 is even better. So that is the level where we can detect 1 myeloma cell in 1 million of the bone marrow cells. So why is this important? MRD is one of the strongest predictive factors of outcomes in myeloma. This here is a kind of made up schematic graph, but the way that this means, this is the Kaplan-Meier graph, and this is a lot what we use when we look at the response rates. And the flatter this curve here, the closer we are to a cure. So in those that are MRD negative, this is given for any single trial, every treatment that we look at, every single trial, is that if we get to MRD negativity, we're going to see a lot more patients in remission for a longer time. Those that are MRD positive, whether they're in CR or not in CR, they're going to have this here means the steeper the curve, the here means that the time to progression is shorter here than here. So meaning that MRD negativity leads to a longer time in remission. This is also what illustrated here in this curve, meaning that if we get to a somewhat deep remission, then the disease might come back a little bit sooner. Here, this is also a schematic picture. This is 12 months. But the deeper we get in terms of the response, the longer the disease is going to stay away. And here, if it doesn't come back at all, that's when we start talking about cure. So there are different technologies that we use for measuring MRD. In the bone marrow, which is the standard, we have flow cytometry, and then we have VGJ sequencing. I'm going to touch upon those briefly as well. Going forward, what we're going to see, hopefully more and more, is the blood-based technologies where we have mass spec, we have circulating tumor cells, and we have cell-free DNA. So for the blood-based technologies, those are more of the standards. Those are the ones that we kind of use both in clinical practice and in clinical trials. Flow cytometry, the most common one is what we call Euroflow or next generation flow, NGF. This is very sensitive. It can detect 2 cells in a million, so 2 to the minus 6. The pros of this technology is that you can use it anytime. You don't need to have the baseline. And there's a quick turnaround time. So we can use it anytime and we get the readout pretty quickly. And the more, I'm not going to go through all of these techniques, but we run these samples through a laser and through different colors and different antibodies, we can really identify which cells are the myeloma cells. And the more complex this is, the lower the better the sensitivity is. The cons then of this technology is that we need a bit of a larger volume of the bone marrow, and we need to use it on fresh cells. So we need to do this right away. The other technology is what we call the next generation sequencing, NGS, which then looks at VGJ, which is the gene that, or part of the gene that encodes for the heavy chain, or so part of the M spike. This can be very sensitive. We can detect 1 cell in a million. The pros of this technology is that we use a smaller volume and we can use it on stored samples. Cons is that we need to have the baseline sequence. So we need to have a baseline sample in order to use it for follow-up. And the analysis takes a little bit of time. So here, what we use is that every single antibody here has a unique VDJ sequence, and this is part of the gene, and this happens during the cell development. So the way that we see this is that in all of the different cells, in someone who's healthy or a healthy bone marrow, we see that there are many different cells and they all have different sequences here. These are the DNA sequences that then will be detected by this technology. In someone who has any type of B or C or plasma cell malignancy or disorder, we see that there are a number of cells here that are clonal, so they all look the same. So that means that when we do this, we're going to see a lot of these cells which have an exact similar sequence. So we can then say, okay, this is the sequence that is associated with the myeloma cells, and then we can use that to detect the disease, to look for the disease over time. So this is so if we look at the schematic picture, this could be true for either of them. This is for the VDJ sequencing more specifically. We have the treatment start. We have lots of cells. We know what they look like, so then we can look at them when the disease responds, and we can see if these cells are here or not. If we then see it starting to come back, we can see that the MRD goes to a little bit higher level, and then after somewhat of a hopefully longer time, we see the disease kind of actually progressing. And we'll talk more about this time here as well a little bit later. So the blood-based testing, that's what we all want, because everyone prefers blood tests instead of bone marrow biopsies, of course. This is still a bit under development, but there are several different techniques. The mass spec is the one that I think is the furthest. So we have mass spectrometry, where we look at the M spike, we look at the specific proteins. We can look at the cells with flow cytometry, and we look at the DNA from the cells as well. What happens with the mass spec is that we take this protein, we take all the proteins in the blood, we kind of cut them up into smaller pieces, and then we can see here, you still can see that there is, wait a second, we see that out of all of the normal cells, you still see the M protein here. So this is a much more sensitive method than the serum electrophoresis and the immunofixation that we use now in standard practice. There, so as I said, these are still in development. The mass spec has a concordance with the bone marrow around 85%, so it's not perfect, but it's still very sensitive. And hopefully going forward, how we can use this, it's not yet that we can fully replace the bone marrow biopsies, but we can use this to look what is the disease going? Is there any dynamic? And then we can use that then to time the bone marrow biopsies. So in many clinical trials, or sometimes in clinical practice, we do these assessments kind of on a regular basis. So this might lead to that we instead can use this, and then we can guide and say, okay, we don't need year 1, we don't need year 2, but maybe year 3, we're seeing a difference here. So that's the time to do the bone marrow biopsy. So how do we get to MRD negativity? So we have better and better drugs. That's the short answer. So here, then we do have, this is a schematic picture of all the myeloma drugs that we have had approved over the last many years. So we have gone from initial therapy, doublet therapy to triplet therapy to now using quadruplet therapies. And we have all the new drugs here, the CAR T cells, bispecific antibodies, and so on. So I'm not going to go through all of the different trials here, but I'm going to touch upon a few and just give an example of what the MRD can look like. This is the Perseus trial. This was presented at ASH in December. This graph here looks at the progression-free survival. And by that, we mean the time from starting treatment until throughout the remission, and then as the disease starts coming back, that's when we call the progression. So this is from time to start until the disease progresses. So here, what we're seeing after 4 years in the group that received the combination of Darzalex or daratumumab, bortezomib, lenalidomide, dexamethasone, after 4 years, 84% still were in remission. In the VRD arm, so bortezomib, lenalidomide, dexamethasone, 67.7% were still in remission. So both still good. Looking at the MRD, here, remember the different levels, 10 to the -5 was 75% in the DVRD group, 47.5 in the VRD group, MRD negativity 10 to the -6, which is a much more sensitive level, 65% in the DVRD arm, and 32% in the VRD arm. So this is clearly better using 4 drugs versus 3 drugs. Then we get to not only the level, but the dynamic and the persistence or sustainability of the MRD. This is getting also increasingly important to look at. So sustained MRD negativity, meaning that these patients that were MRD negative, and a year or more later, were still in MRD negativity. And this was 64.8% in the DVRD arm, 29.7% in the VRD arm. Going on to the next trial, this is just the MRD data. This is the ISKIA trial, the isatuximab, carfilzomib, lenalidomide, dexamethasone trial. So ISA KRD versus KRD. This is MRD negativity over time. So the first column here is after 4 cycles. The next one is after a transplant, and the third one is after another 4 cycles. So 4 cycles, transplant, 4 more cycles. And what we see 10 to the minus 5, 77% in the ESA KRD arm, 67% in the KRD arm, and in the 10 to the minus 6, 67% versus 48%. So very high response rates in these quadruplet treatment arm. Here's another way of looking at it. This is the Manhattan trial that we did at Memorial Sloan Kettering, where I work. So this is with daratumumab, carfilzomib, lenalidomide, dexamethasone. This is the patients that were on the trial. You see this is the red where everyone started, and then as it gets more orange and yellow and green, this dark green here is the MRD negativity. So we see that around after median of say five cycles, then a lot of patients were already in the MRD negativity. Overall, the MRD negativity in this trial was 71%. Looking then to the CAR-T, this is not frontline. This is a trial that included patients in line 1, 2, or 3. Sorry, relapse line 1, 2, or 3. So those that have gone through the initial treatment and had relapse, but we're still in that early relapse phase. See that, and this was randomized then CAR-T, cilta-cel, versus standard of care. So we see high response rates, high overall response rates, and the MRD negativity at any time point during the trial was 60.6% in the cilta-cel group, 15.6% in the standard of care group. So even more treatments, and in later lines, we see still very high MRD negativity rates. This is an example of one of the bispecific trials. This is with teclistamab. And here the overall response rate, 63%, MRD negativity rates, 26.7. This is not, you see, this is not maybe as high as the other ones, but remember that these patients that run this trial, they have gone through a median of 6 lines of therapy. And so these are patients in a much more advanced disease stage. So these are really impressive numbers for this patient group. So next question is then, we know that MRD is important. We know that the deeper the MRD, kind of the deeper the response, the longer it stays away. And we have really good treatments to get to MRD negativity. The next question that as clinicians have been talking to the FDA for a very long time is that if we can use this for regulatory purposes, so can we use this to get drugs approved earlier? And the reason here was that the therapeutic landscape in myeloma has greatly advanced. So we see in all of these clinical trials, we see overall response rates are close to 100%, complete responses are over 70%, median progression-free survival in these early trials that I said, over 6 years, and median overall survival in any of the trials is over 10 years. So that means that we have really good treatments, but the trials take a very long time. If we look at PFS, it's going to take 6 or more years to get any outcome from this trial. So how can we then use the data that we have to see if we can have the MRD as a marker, as a surrogate marker for PFS? So there's been lots of work with many different centers, specifically the in Boston and Miami, and there's 2 different groups that, and Mayo Clinic, really an impressive joint effort to prove that MRD is actually a surrogate endpoint. So MRD negativity correlates with PFS. So instead of looking at the PFS, seeing that can take 6 years, can we look at the MRD negativity rate instead? And what this was then to a kind of an expert meeting or an advisory meeting that happened in April of this year, where all of these experts presented this data to the FDA in an effort to say, here, look, we can now prove that the PFS actually correlates to MRD. So therefore, we want to use MRD. So these are some of their slides that I'm going to show now. This was the meta-analysis done from the Boston group. There are 93 publications, so they pooled all the data from these 93 publications. There were over 8,000 patients, and clearly we see that those that were MRD negative, that's the blue curves here, those did better in terms of progression-free survival in comparison to those that were MRD positive. And this is then, you see 3 different groups. These are the newly diagnosed transplant eligible, so those that are on the younger side, the newly diagnosed transplant ineligible, and the relapsed refractory patients. So this really goes across all the different patient groups. And here to prove that, in another slide, we see that this is the newly diagnosed transplant eligible, newly diagnosed transplant ineligible, and the relapse refractory. The MRD negativity rate really correlates with the progression-free survival across all of these 3 groups. So what this advisory committee then said, the ODAC said, they actually unanimously voted 12 out of 12 expert recommended MRD to be approved as an early endpoint for accelerated drug approval in multiple myeloma. That still means that it has to go through, in order for a drug to be fully approved, this is an accelerated approval where we can still use it, but it has to be then proven with progression-free survival and in large comparative trials to get full approval. So how do we, in clinical practice, how can we, or in trials, also, how can we use MRD to guide treatment? Because this is really one of the main points that we would want to do. In those that have a high-risk disease, or we still see disease after induction, can we in some ways tweak the treatment or escalate the treatment? Can we give a bit more treatment to aim to get to MRD negativity? Or in those that have more of a standard risk, that have an early MRD negative time point, can we then cut back a little bit on the treatment and then avoid over-treating those patients? There's lots of trials that are actually looking into this now. One of them is the MASTER trial, and this is the wrong reference. This is Luciano Costa from the Alabama group. So this is the MASTER trial, which I think was a really interesting trial concept design, where they took all patients treated with Dara-KRD 4 cycles. They looked at the MRD, then they did transplant, looked at the MRD, looked at consolidation 4 cycles, looked at the MRD, and then those that needed did 4 more cycles, and then maintenance. Looking at all of these different MRD time points, those that had MRD, those that were MRD negative in 2 consecutive time points, that was then called MRD sure. And these patients could then cut back on treatment and go off treatment with a very close monitoring. So this is, as I said, a very interesting trial design where we use a very powerful drug combination, and we look at the MRD to see those that are MRD positive may need more treatment. We're going to push to get them into the MRD negativity. Those that already had MRD negativity, we cut back on treatment. And when we see that here, the outcomes of this is that a lot of people actually then could come off treatment and continue to stay in. Not everyone has stayed over time in MRD negativity, but a lot of people are still MRD negative on this trial. What we're looking into more, also we have one trial at MSK, and then there's one trial in Chicago, is looking at the maintenance phase. And one of the reasons here is that maintenance, yes, we know that it's beneficial. We see that it does prolong the progression-free survival. However, we also want to select those that really need treatment after a while, those that need maintenance, because we still know that there are some side effects with maintenance. So those that really need it after a while, or those that are in an MRD negative state, can we stop? So here, what we are looking at in our trial at MSK, run by Dr. Corday, those patients that are on maintenance that have MRD negativity, and then 3 years of maintenance, and again are MRD negative. So at least 3 years in between with 2 MRD negativity time points. Those are able to go on the trial and then stop, but with very, very close monitoring. The MRD2 Stop trial is also a very interesting trial run by Dr. Derman in Chicago. These patients are those that are eligible and those that have 2 years of MRD negativity. And here they're using a special technique, which enriching a magnetic bead technology to enrich the plasma cells, so they can actually get an MRD level at 10 to the sensitivity level to 10 to the -7. So here, these trials are still ongoing, so we don't have the full results yet, but we do know that most patients that come off are more than 1 or 2 years out and still in remission. That said, there was a trial coming out from the UK where they did an analysis. The trial was not designed really to look at that, but they looked at those that were on maintenance for a longer period of time. This was lenalidomide maintenance. They looked at 3 years. Those that and if is there a benefit to continue continue maintenance after the 3 years? And what they saw in that trial was those that were MRD positive after 3 years. Yes, maintenance still has a role there. So in someone who's MRD positive on maintenance, I'd not recommend stopping maintenance. In someone who's MRD negative, then we can talk about it, we can discuss it, we can see if this is a good thing or this is a good idea to stop, but with then very close monitoring. So then, is MRD negativity always worth it? This is kind of where it comes into a very tricky question. And here I would say no. So yes, we can look at all the clinical trials. We can look at all the data that I just showed, this meta-analysis of over 8,000 patients. However, there are other things that are important. So it is in each and every person. We want to find, this was very nicely put by Dr. Runa Paiva, who is one of our kind of MRD experts and a pioneer in at least the Euroflow. Optimal balance between treatment efficacy and toxicity is of utmost importance to preserve quality of life. So yes, MRD is really, really important, but we always have to think, we have to be very careful. We have to really talk to each and every patient and say, there's a little bit of MRD negativity here. Do we really need to get MRD negativity? And what is the cost? What is the toxicity? What is it worth to get to that extra MRD negativity spot? So here, not always. And the other thing that we saw in one of our trials this was Dr. Ben Diamond, who's now in Miami, who published this. This was 100 patients that were on lenalidomide maintenance, and we monitored the MRD over time. So this overall is the result. This is everyone who started MRD positive, MRD negative on the trial. Overall, we see after 5 years, most patients are still in remission, so very good. Next, we looked at the MRD negativity. So here, MRD negativity, almost flat curve, very, very good, very long remission. MRD positive, here we see that there are some patients that have relapsed and progressed and then needed to come off the trial and to switch treatment. However, the next thing here to look at is the MRD dynamics. So we then divided into 3 groups. Those that were MRD negative stayed in MRD negativity. Those that had a little bit of MRD positivity but stayed in MRD positive, so stable MRD positivity, still very long remission. These are not that many patients, so we have to be a little bit careful, but those that were MRD negative and then turned MRD positive, so we see that there's a dynamic to this, those are the patients that we should monitor really, really closely. And that's kind of one of the more important things to look at if there's a change in the MRD. Is it sustained or is there a change? There was 2 recent publications that also looked in the change here. So looked at the predictions of MRD, what we then call resurgence. So MRD negativity turning to MRD positivity. This was from the Forte trial. So this is from Italy. There were overall, this is patients that were divided into 3 arms. There was KRD, KRD plus transplant, or then KCD, so carfilzomib Cytoxan with transplant. And here, overall, 65% of everyone on the trial was MRD negative. After 15 months, 60% of those were still MRD negative. So that's a very long time, very good response. 39% had lost their MRD. So they had what we called an MRD resurgence. And then they looked at the predictors of this MRD resurgence and saw that the predictors of this were high-risk cytogenetics, so 2 or more high-risk cytogenetic features, 1 Q gain, circulating tumor cells at baseline, and if it took a longer time to achieve MRD negativity. Similarly, this is from a Spanish study that was also published in the same paper of Blood, the same journal, or same volume, same issue. And this was a pool of different clinical trials. What they looked at here was after 73 months, all of those that were MRD negative had lost their MRD negativity. So 42% had MRD resurgence. Predictors of the MRD resurgence was still high-risk disease, so ISS3, circulating tumor cells at baseline, and if it took a longer time to achieve MRD negativity. So looking at this, if we summarize these 2 trials, we see that overall, we see really long response rates in those that are MRD negative. The factors that predict if the loss of MRD, so MRD resurgence, are overall high-risk disease, high-risk cytogenetics, circulating tumor cells. So these are kind of the usual suspects as well. So again, looking at these 2, the Forte and the Spanish trial, there are different ways, or kind of how, if we summarize these findings here, there is still a difference with going from MRD negative to MRD positive. And still, that does not mean that we see it in the blood or that there are any symptoms or PET scans can be negative. Biochemical relapse is when we start seeing it in the blood. Still, patients can be asymptomatic for a very long time. And then what we call CRAB relapse, or like actual relapse, where we see high levels in the blood, or we start seeing lesions on the PET scan or so. So there are different levels of this. And if we look at these 2, the Forte trial, the Italian trial, and the Spanish trial, the time from MRD resurgence, so when we start seeing the MRD, to actual disease relapse, still a very long time. It was 22 months, so almost 2 years in the Italian study, and then 39 months so over 3 years in the Spanish study. So going from MRD negative to MRD positive does not mean that the disease is, of course, everyone is different and everyone has a different dynamic, but that just means that we really have to be vigilant in monitoring. That does not mean that we have to change treatment right away, or that in those that are off in the maintenance trials, if we start seeing MRD, does not always mean that we have to change. We can still monitor off treatment or on the same maintenance treatment for a very long time. So taking this all together, yes, MRD negativity is very important, but it's not everything. With better treatment, we see higher rates of MRD negativity. Both the depth and the kinetics of the MRD are important. What we want to do going forward is to use MRD to escalate for those who need it, or de-escalate treatment for those who do not really need it in terms of treatment. There are trials that are ongoing for this. There is several trials looking at do we really need transplant, which I did not really touch upon on here. How can we de-escalate or escalate treatment? There's a follow-up to the master trial, etc. Going forward, blood-based technologies, I think, are going to be largely, but not always, replacing the bone marrow biopsies. And as this quote that I showed, it is what it really comes down to. It's a discussion with each and every patient of how do we get to MRD? How important is it? What are we willing to treat in terms of get there, and then how does the most important really is the quality of life, and how does that matter in terms of all of this. So with that, I would like to thank everyone here. This is the team at MSK. And of course, looking forward to the discussion here. I see that there's already a number of questions.
Perfect. Thank you so much, Dr. Hultcrantz, for that wonderful presentation. We had a large turnout, and like you said, there's a large number of questions already. If it's okay, I'll read the question and then give you some time to answer. And we'll get to as many as we can. Again, there's quite a few right now. So first question that came in says, why do people with MGUS or smoldering myeloma have more than 1 in 100,000, but that doesn't raise an issue?
That's a really, really good question. So you can almost, so in terms of the MGUS or smoldering, the question is, when do we start treatment? And in MGUS or smoldering, we still know that patients can be in that kind of asymptomatic phase for a very long time without treatment. So this is a little bit different in terms of different diseases, if we see that the disease is curable or not. So say in breast cancer or other cancers where we see that, if we treat early, we have a higher chance of cure. We would love to have that for multiple myeloma, but we are not really there. So therefore, it really comes down to a timing of treatment, where we see that what is it, kind of same thing, coming to that, how important is it to get to MRD negativity? For MGUS, most people with MGUS are never going to progress to multiple myeloma. So most people are never going to be bothered by this and never going to need treatment. That's number one. For smoldering, the disease has already shown that there is a little bit of higher risk of, or kind of there is a higher disease burden, but it can still stay kind of in this dormant phase for many years. And so for those smoldering, especially the high-risk smoldering, the more important thing is to really look at, or to monitor very closely. And if it gets to a point where it starts giving symptoms, then we want to treat. So it's really a timing of treatment there. You can compare that a little bit to that stopping MRD or stopping maintenance and then monitoring, because if you see a little bit there, that does not mean that you need to start right away, really. It could still be years until you actually need to change treatment, or you need to start something new, or you need to start if you're off. So looking at that kind of iceberg analogy, if you have a little bit, it's probably not going to bother you that much. If it gets to slightly a little bit more, probably not even. But if it gets to a higher level, that's when we want to start. So, and for those that have myeloma, the disease has then showed itself that it can get to that, higher disease level burden, so it can give symptoms. So that's where we want to be a bit more on top of it in terms of treatment. But very, very good question.
Yeah, absolutely. Thank you. Next question just says, samples are bone marrow or serum. So I'm just assuming they're looking at MRD. Of course, you talked about we're looking forward for blood based testing. So
yep. So all of all of the results that I showed now are in bone marrow. So the serum is I mean, we're getting there, but it's still in development, and those technologies are not yet FDA approved, so we can't use. We're all very eager to start using them, but we can't really yet. So we have those in all of the clinical trials, but we can't yet use them in practice, unfortunately.
Yeah, absolutely. I'm sure we're all looking forward to that. And next question is, can any center do Euroflow or NGS VDJ?
For the flow is a little bit more dependent on the specific pathology labs that you have. For the Euroflow, that's a pretty standardized technology, and there's a standardized software. At MSK, for instance, we have a really good flow team, so they've developed their own, which is the Euroflow. The standard is 2 tubes with 8 colors. We have 1 tube, 10 colors. So and we've tested that it has the same sensitivity. So most can do that, yes. For the VTJ, that is a send-out sample, so that goes actually to the company that then it's called Adaptive that do this clonoSEQ, the FDA-approved clonoSEQ. So that one, at least in the US, should be able to be, of course, there's logistical issues and contracting and insurance and all that, but we have not had any, and we recently switched to that, and we've not had any issues in terms of insurance or so, and so it's more really of a logistical thing, at least in the US.
Perfect. Our next question says, does site of the bone marrow sample need to be consistent, same hip, etc.? So there was a question later on as well that kind of ties into this from Gretchen, which says, how reliable is MRD negativity across different sample sites? So are we looking at a targeted type biopsy or just a biopsy at random?
So all of the samples here is from one random site. In the trials, we really don't really specify if it's right side or left side or so. The more important thing, it is, yes, the myeloma can be a little bit patchy, but for the MRD, we usually get, like, the more important thing is the sample quality. So as long as we get cells, then we can usually do it. So if it's getting into the technical things here, when we do a bone marrow biopsy, we do the biopsy itself, but then the aspirate, that's kind of where we aspirate out a little bit of the bone marrow. That can sometimes be what we call diluted with blood. So sometimes there is a lot of bone marrow cells, but sometimes also there are some blood cells in that. So that's kind of more important. How good is the quality and how many of the cells are there? And that doesn't really matter if you do it on the right side or left side or so. So there's we have done a lot of efforts, at least at MSK, to trying to get this to be good quality and kind of have a technique where we get a lot of these bone marrow cells. Because of course we want to look at cytogenetics, we want to look at flow. We do both, so we do both flow and NGS actually, and then we look at a number of different things as well. So if you get to the more kind of you aspirate, the more blood it's going to be after a while. So it really, I hope everyone's most people have gone through this. So it really has to do with the sample and the quality and the number of myeloma or plasma cells that you get in the sample, rather than if you do it right side, left side, if you do it only on one side or only on the other side. But looking at kind of response assessment, we only talked about bone marrow and blood MRD. Of course, we want to look at the PET scan as well, because we weigh in all of that in the response assessment. And I think that's one of the reasons why blood is going to be more interesting as well, because there you have a circulating of protein, so it captures all of the different sites. If there's low level myeloma in different sites, clinically it's not a big thing. It doesn't really matter if it's right side, left side, or so. But the more sensitive our technologies get, the more it might matter.
I love it. Perfect. So our next question is, blood NGS or blood mass spectrometry going to be widely available sooner, and if so, when?
NGS is available. That's an FDA approved technique. So that one has to do with if your center has that set up and can do that as a send out sample. It's getting more and more widely used. Mass spec, I don't have a timeline. I hope it's going to be soon. I know there are several companies that are working really hard at getting all the data together and discussing with FDA, but I don't have a timeline.
Absolutely.
We are as
Perfect.
eager as you are.
So,
I can promise you that.
yeah. Love it. Our next question is the EuroFlow available at most cancer centers, or does it need to be specifically requested? And how does it compare to NGS?
So they're very comparable. As the EuroFlow, that's just one, as I said, one example of it. Most people, most centers can do flow, whether it's EuroFlow or not. Most centers can do flow, and it's going to be good. So it doesn't, for flow, it does not, that was just an example. As I said, in MSK, we use a different, so it doesn't necessarily need to be EuroFlow. That's one of the more widely used ones, and it has a very high sensitivity. But as long as your center does flow, it's good.
In good shape. Perfect.
And that's one of the things that the FDA had that's why it took so long also to get this as a clinical endpoint, because there was so much flow was kind of done a little bit different at all the different centers. So over the past number of years, all the centers have together worked really hard at standardizing this. So I think now if you do flow and you have 10 to the minus 6, 10 to the minus 5, it's going to be similar across centers. That was really one of the requirements for using this as an endpoint.
Perfect. So this one kind of flows right into that. Is there's a big difference between, of course, 10 to the negative 5 versus 10 to the negative 6. As one can be negative with NGF but positive for NFS, does this discrepancy affect clinical trials and treatment decisions?
Sometimes, mostly they are concordant. I would say this is really getting into the very minor details of this. So I would say that most of the time, being positive by 1 or negative by 1 in the clinical trials, and using in a more standardized method, it tends to use the NGS, so the sequencing overflow. But I can't say that there's a huge difference. The concordance between the two methods is very high.
Perfect. And then this one is, everybody's getting excited about the blood MRD test. So it says about how sensitive is blood MRD approximately compared to bone marrow.
So that's the thing. When I said there's 85% concordance, that is to the I have to say at least 10 to the minus 5. So it is, the blood-based ones are going to be really, there are also 2 different methods of doing that. They are really, really sensitive. At least they're 85% concordance with 10 to the minus 5. I don't actually remember on the top of my head if that was also 10 to the minus 6, but I can get back to you. But very, very high. So when we say that they are concordance, that means the same level in the blood as in the bone marrow.
Perfect.
Or kind of equivalent of because of course you're looking at a different method, but the equivalent of being 10 to the minus 5 or 10 to the minus 6 in the bone marrow.
That makes sense. And of course, that's, I'm sure, is something that they're looking at with that FDA approval. Absolutely. Of making sure that it's comparable. So next is there a cutoff time that is there a cutoff time that when a patient is undergoing maintenance therapy and one has not reached MRD negativity, that it most likely won't be achieved? For example, if you're 1.5 years out, 2 years out, and still not reaching MRD negativity.
There's no exact cutoff, but as you're alluding to, patients can still achieve MRD negativity during maintenance. So those that, for instance, goes through initial therapy, go through transplant, and then maintenance. And if there is a little bit of MRD positivity after the transplant, that can turn into MRD negativity during maintenance. If it's been though 1.5 or like 1.5 or 2 years, that might be close to the cutoff where we say it might not happen, but also really there depends on if it's stable, is it moving? That kind of gets into, how much is it worth it to kind of turn that into an MRD negativity, because having a stable low-level MRD positivity, as we saw in our trial, patients were still in a remission for like a clinical remission, and the disease stayed away for still a very, very long time. So there's no kind of, in terms of set cutoff in terms of criteria or so, but clinically, yes, I think 1.5 or 2 years is a reasonable time point.
Perfect. And this ties back, I think, into the bone marrow question with biopsy sites, is how reliable is the MRD negative across different sample sites? I don't want to answer for you, but it sounds like the aspirate is the biggest.
Yeah,
factor there.
exactly. And also looking over time, it can vary a little bit over time, also because of the quality. So usually if we see a little bit, next time if we do it in 6 or 12 months or whatever, if it's a trial or if it's doing a clinical kind of follow-up, if we see that it's positive, then it's usually true. But the quality, the cells are, it's such a low level at that point. So sometimes when we look at the percentage and it says 0.002 or it's 0.003, does that really matter or so? That's kind of when the quality of the sample comes in. Is it really reliable that we can detect those very low kind of, so if there's a big change, if it goes from 0.0003 and then next time it's 0.1, that's a pretty significant change. So depending on if there's a small change or a dynamic over time or so, that's more important than to look at the, it's a very good questions, very hard to answer.
Yes, absolutely. There's a lot of nuance.
A lot of it is, as I said, a lot of it is the actual quality of the samples. And if we do an aspirate at one time point, if we do an aspirate at 6 months or 12 months later, it might be a little bit, did we get, 2 million or 3 million total cells there? And does that change the overall calculation?
Perfect. And we've got a lot more questions coming in. I'm wondering, with all the added questions, perhaps we could write down some of them and maybe off camera or in an email, get a few more of these answered, because I want to be respectful of your time, of course. But let's go just maybe 1 or 2 more, if that's okay.
Yeah, absolutely.
Okay. So next question is it standard of care to use DARA RVD for consolidation post-transplant for low-risk multiple myeloma?
If you look at the Perseus trial, then the trial was built so that it was 4 cycles of DARA RVD first, and then transplant, and then 2 cycles. So that is, yes, that is a standard. Not all centers, if it's someone who's MRD negative, do those extra 2 cycles, and sometimes even what we do is kind of do all the 6 cycles before the transplant. I think it's important to do 4 or 6 cycles, but it is the trial itself. It was designed to do 4 cycles, transplant 2 cycles. So yes, it is pretty much of a standard.
Perfect. This next one, it looks like they had a relapse 6 months. They were MRD negative for 3+ years, and then I had a relapse after stopping Revlimid 10 milligrams. Now on KVP. Wonder if that's a question of is that somewhat
Right.
a normal course of action?
Yeah, I think there are, I see a few of the questions here, so that are kind of are more individualized or so. I'm more than happy to answer those a little bit more offline, and but usually here we go through those that are more of a general question. So I'm happy to answer these, and I'm happy to answer them offline, and I'm happy to always contact me or so. But usually we try to stay with the. But that looked unfortunate. That kind of is an example then of more of the MRD dynamics where we have certain ways of where we can try to predict that, but of course, none of our prediction models is 100% for everyone.
Absolutely. And maybe we'll end there unless you've got another one you wanted to answer quickly.
I see a few here in terms of, there's one here in terms of the maintenance and consolidations would be for drugs or Revlimid
Okay.
only. I think that was, the maintenance is really, really being discussed in both among kind of the myeloma doctors, but then also discussed in terms of in clinical trials. And usually 4 drugs is a limited consolidation, but 4 drugs is usually not something that we do for a long-term maintenance. For maintenance, the standard has been lenalidomide or Revlimid for a very long time. It is being questioned. We have a trial now of Revlimid or daratumumab. I know there are a number of trials also ongoing with Revlimid and daratumumab. So one arm could be Revlimid, the other one could be Dara-Rev. And in the Perseus trial, I think that was a really interesting design. So for which was then MRD tailored. So after the 4 cycles, if 4 induction cycles, transplant, and then 2 more cycles, what they did was in the Dara arm, so those that received initial Dara-Rev, they Dara-RVD. So they were on Dara-Rev maintenance, so dara-lenalidomide maintenance for 2 years. Then they did a new bone marrow and looked at the MRD. So those then that were MRD positive continued on 2-drug daratumumab lenalidomide maintenance. Those that were negative could stop daratumumab and continue on lenalidomide only. So I think that there's a lot of trials that are ongoing that are kind of trying to optimize maintenance with all these strategies of using MRD to really tailor the treatment to maybe give a bit more for those who need it, for those that are MRD positive, more high risk, and potentially stopping for those that are lower risk or have a sustained MRD negativity.
Perfect. Thank you. Were there any others or?
In terms of, I see there is a question here also from, in terms of the standard or high risk cytogenetics. Yes, we see that those that tend to relapse or have a harder time to get to MRD, and those that have a MRD resurgence in those 2 trials that I mentioned, those are more the high risk, especially those that have 2 or more high risk features. Meanwhile, those that then on the other hand, if you kind of flip it and say that those that have an MRD tend to stay in MRD negativity, those are more of the ones that are standard risk. And the question here was specifically 11-14. And not all, there's a lot more standard risk than 11-14, but that's definitely one of the more standard, or standard, we don't really call it low risk, we call it standard risk. That's the lowest risk category. Just on circulating tumor cells, that is measured through a blood sample, and it's through flow cytometry. And that is also not something that is very standard. That's really used in clinical trials so far. The high-risk cytogenetics, usually the high-risk cytogenetics are those that have 2 or more of those that are 414, 17p deletion, 1416, 1420, 17p deletion. So those are the more of the group of the high risk.
And I'll be getting better at being a moderator here. I appreciate you.
No, don't worry. I'm scrolling through here.
The good question.
There's a so the last question here is standard MRD negativity is defined at 10 to the minus 5, not 10 to the minus 6 level. Yes. So the FDA, what the FDA said is that anyone who does MRD in terms of flow or NGS or so has to have a minimum of 10 to the minus 5. But we're always aiming at 10 to the minus 6. But as I said, a lot of that depends also on the specific sample. So a lot of the times when we get when we do a bone marrow and we got all of the reports, it gives us a sensitivity for that specific, even though we have the possibility of doing 10 to the minus 6 with our flow machines and with our NGS, it might be that this specific sample were not that many cells, or so it was kind of the quality that was not optimal for this specific sample. So it will give us a specific sensitivity level for every single sample. So we're always aiming for 10 to the minus 6, but for many reasons, or kind of various reasons, it could be 10 to the minus 5. So when we get that minimum 10 to the minus 5, always aiming for 10 to the minus 6.
Right. All right, if it's okay with you, we'll go ahead and wrap up. I see one last comment here from Keisha, who is one of your patients, and she said she wants to thank you, of course, for all of your hard work, and your presentation was excellent. We all really appreciate your expertise and time with us today. I'll go ahead and share my screen and we'll finish up. Dr. Hultcrantz, thank you so much.
Thank you so much. Thank you, everyone. Thank you for excellent questions. And thank you so much, Cynthia and HealthTree, for everything that you do as well.
Of course. Good. Okay. So just a couple of things as we finish up today. We want to make you aware of any of our upcoming events here. Oops, there we go. We'll share that one. Our next MRD session will be happening this fall, so be on the lookout for details for that information soon. Here are a few other upcoming events. On Tuesday, June 25th, we have our Myeloma Caregivers Group that will be learning about handling difficult decisions and conversations with Georgia Anderson. Wednesday, June 26th is our virtual HealthTree Cure Tour. And then Thursday, June 27th, our Black myeloma community will hear from Jay from the HealthTree research team. We'll discuss exploring HealthTree research opportunities for the Black myeloma community. The link to sign up for any of those events and many others is down at the bottom of this slide and will be sent out in the follow-up email within 48 hours of the event's completion. I would like to again thank our sponsors, Adaptive, AbbVie, Genentech, Johnson & Johnson, Pfizer, Regeneron, and Sanofi. I also want to thank all of you for building this strong community and for, again, allowing me to be a part of it. I've included my email here as I'm new. I want to make sure that you know that I'm here and available for you if you have any questions or simply want to reach out. I appreciate all of you and hope that you have a wonderful day.